Ladies and gentlemen, and a warm welcome from a beautiful day here in Cape Town. It's been very wet, but now I can say there's not a cloud in the sky, and it gives me great pleasure to welcome Professor Steve Jeffery this afternoon, and he's going to be speaking about the very contentious topic of TVT and stress incontinence management. We're looking at the surgical management, and what with the recent current debate around is mesh safe and should mesh be used in gynecological surgery, it's a timeless approach to this question. Is TVT still a mesh option, or should we have other forms like Bulkamid and mid-urethral bulking agents? And we're going to ask Steve in a second to share his screen. I'd like to thank the Pelvic Floor Foundation of South Africa for sponsoring this, and also, excuse me, our technicians for being able to set this up. It's going to be very popular. We've got over 100 registrations as we speak. It shows exactly how popular this topic is. As the court cases loom large for the use of mesh in gynecology, it's a topic that has legs. We're going to be talking about mesh and options for mesh in gynecological surgery, I predict, for many, many years to come. Steve, how do you feel about mesh in gynecological surgery?
I feel that it's still a very important option, and this is going to actually form a very important part of our discussion this afternoon, and that's why I chose this topic about the TVT and whether it is actually an option. Thanks, Roberta. Roberta's just bringing us a little bit of milk for our coffee, so that's the slight interruption at the moment. Very important. Thanks.
Thanks, Roberta.
Yeah, some important things in life.
And Steve, the other thing is this. Many patients say to me when we're talking about TVTs and meshes, is this still an option? What about older options? They say, what did we use before? And I say, in the past, we had STAMIs, we had RASs, we had needle suspensions. And although these were very safe options, the success rate was so poor as to make it actually a very poor option for the use of surgical management of stress. And if you're going to say to a woman, there's a 40% chance of your cure in the short term, they'll say, well, why bother? Why have an operation if it has such a low success rate? And of course, this is exactly opposite in mesh. So Steve, without further waste of time.
Thanks so much.
Would you like to kick off and share your slides?
Yeah.
Is TVT still an option for stress urinary incontinence surgical management?
Absolutely, yes. And I know there will be questions along the way. Due to the logistics of presenting from the same screen, we'll answer all the questions at the end, and we'll definitely leave time to answer all the questions.
So you will leave a bit of time to address.
Yeah. Let's do the question, but you can obviously interrupt me along the way, Pete.
We don't mind if I interrupt you, Steve.
Never do. And so TVT is still an option. As Peter said, there's currently a class action against two mesh companies in South Africa that has created a lot of consternation. When I want to do TVT or sacrocolpopexy in patients, the question arises almost invariably by most patients who at least have some connection to the internet or have had a discussion with their daughters or sons in the UK particularly. So that's why I actually thought I'd bring up this option of an operation, which is actually still a very good operation, but produces lots of discussion and issues and anxiety amongst patients who potentially would go through this. And you'd not be doing due diligence to your patient if you didn't discuss the mesh issue prior to embarking on a TVT. But this is the classic sort of patient that we need. You want some paper, Pete? There?
Looking for paper,
yeah.
Steve.
So, and there's a pen, Pete. Sorry, all the logistics, yeah. So,
very scientific.
Yeah. So this is the classic sort of patient you might see in your office, a 46-year-old, severe urinary incontinence, no urgency or nocturia, can't run, laugh, walk without leaking. I'm seeing a lot of young patients who want to do things like the big marathons, running races, jumping on the trampoline. And stress incontinence is certainly a huge issue for these patients. And in this patient, 10 to 15 years ago, it was actually quite simple. We would either do a TVT which in this case is the retropubic procedure. And for those of you who aren't really that familiar with some of these operations, this is a very simple procedure, small cut in the anterior vaginal wall of about 1 centimeter just below the urethra. And using a special needle, we thread this tape under the bladder neck. And in most cases, it can take less than 15 minutes to do. And patient goes home, if not the same day, the next day. Very nice operation, and the success rates are really good for this. This is the alternative. It's called the transobturator tape or TVTO. Very popular. Thousands were done in South Africa up until quite recently, and I think many people still do it this way. But I still do prefer the retropubic tape. And currently in my practice, I still do a lot of these. I mean, recent statistics, anything up to 150 to 200 of these a year in my practice. So this is still a very commonly performed operation in my practice, despite all the dramas related to the mesh problems.
Steve, just go back if you don't mind.
Yes.
Just before that slide you're going to show.
Yes.
The question arises, the next slide you're going to say this TVT and the mesh has been withdrawn from Scotland, from America, from the
you've
UK.
seen these slides before, no?
No, I happen to be. Now, the question I wanted to ask you actually, if they were withdrawn, are they still available in our country, South Africa, as a surgical option for management of TVT?
Yeah, absolutely. I mean,
So
we've got them on our shelf, yeah. They're actually available in nearly every country in the world. I mean, I think you can even do them in the UK still.
TVT,
Australia,
yeah,
you can still do them. If you're going to do it in the UK, you have to give a patient a decision aid, which is, I've seen it, it's about that thick, which takes them through every single option with lots of pictures and complications, etc.
Don't they find that confusing? Because if you're going to give a person too much information can befuddle and confuse you rather than clarify the issue.
Yeah, I think that they do overcomplicate it, and the doctors who work there have told me that it's extremely frustrating managing patients with stress incontinence. And we do have patients traveling to South Africa for TVT, which I've had. Yeah, I've had a few patients from the UK come for their surgery. Yeah, not only would you have to work quite hard to get a TVT operation, but you would have to wait very long. I know in some places it's more than a year waiting list. Can it be up to 2 years waiting for something like this? So it's not an easy operation to get in some parts of the world. But bottom line, I still think it's actually quite a good option for patients with stress incontinence. This was the very first time that we started to realize that there was a problem, or that there was a political problem with mesh. And this is Alex Neil. He was the Scottish Health Secretary. Women who had the TVTO, which is this one, who presented with pain. Now, there are ligaments going that attach onto this pubic ramus. Do you know which tendons attach onto your feet?
Yeah, the tendon subfusus longus obscurus.
Well, it's sartorius, adductor longus, adductor brevis.
Adductor.
Adductor brevis, adductor longus. Anyway, the bottom
adductor brevis.
Bottom line is that there are muscles that attach along here, and in some patients you can get groin pain, and you've seen them, I've seen them, and those patients do need help. They often do need a release of the tape, and unfortunately I don't think some of these patients got that sort of help in the Scottish healthcare system, and they then went straight to the Scottish Secretary of Health, and these became huge issues. They formed massive groups, and if you go and look online, I mean, you'll find lots of these. This is a Twitter group, #TVT, new mesh. If it's good enough for chickens, it's good enough for women. And so these are old things now, but these are present on the internet, and there are groups that have been actively campaigning against the use of any type of mesh. And this is the sort of thing that you're going to encounter, and you do need to be careful of when you are embarking on doing a TVT in a patient. And every patient would need to have a discussion about these issues before going and having a TVT. So that's why I wanted to have this discussion tonight about this. Some of the media was very imbalanced, and unfortunately this is a professor of evidence-based medicine in Oxford, who went so far as to say that the vaginal mesh is the new thalidomide, and
That's preposterous.
which was put a little bit over the top, I think. And so there's been quite a lot of discussion. There's been this whole sort of bipolar attitude towards the TVT mesh, where on the one hand, you've got these very strong opinions from even some of our medical colleagues. As you can see, the C. Brody said one life ruined is one too many. Carl Hennigan, mesh devices must be banned. And whether some say the risks outweigh the benefits, not bearing in mind the huge hundreds and probably millions of women whose lives have been remarkably improved by this device.
Steve, the problem is this, that any operation, any genuine operation does have complications. And it's sad to say that mesh operations do have complications, as do normal operations. For example, when I started before mesh, which came out in this country in 1997, the first operation, TVT, was done at Groote Hospital by
Dr. de Jong.
Well, with the assistance of Christian Falconer, 1997. And until then, hitherto, the operations was Marshall Machete Krantz and STEMIs. And having done many STEMIs and David Lee slings previously, David Lee slings and Birches and Marshall Machete Krantzes were good operations, but their complications and side effects was massive. This, for the first time, was an operation. We're talking TVTs. We're not talking about other forms of mesh for prolapse. TVTs was a genuine operation with a considerably reduced footprint of complications, Steve.
Yeah, and absolutely. And I think in terms of what we had then and what we have now, it's remarkably better. And the number of patients that have been improved, the lives that have been improved, far outweighs the number of patients who have had adverse events. It's also, in my opinion, the most investigated operation in incontinence, and maybe one of the most investigated operations in gynecology.
By far.
There must be thousands of publications on the TVT.
Tens of thousands, Steve. So it's well investigated. But the big thing is to differentiate between mesh for prolapse and a TVT. Mesh for prolapse is a different question, a different argument for a different forum.
Absolutely. So just on the other side of the scale, you have IUGA, the International Urogynecology Association, where they have actually put out a document where they say there's robust evidence to support the midurethral slings, as you can see, MUS, from over 2,000 papers. The Cochrane midurethral slings are the most extensively researched surgical treatment for SUR and have a good safety profile. And even the MHRA, which is the Medicines Health Regulatory Authority in the UK, has also even said the benefits outweigh the risks. Unfortunately, despite there's excellent evidence for the use of these things, there's been a massive reduction. There was a massive reduction after the introduction of this issue by the Scottish Parliament. And you can actually see the types of operations that are done for stress incontinence. The Birch operation was very popular because it was actually just probably one of the more successful operations up until the invention of the TVT. And you can actually see in orange here how as the TVT was introduced in about 2001, which was when I was a registrar with Pete, actually, and I saw one of the first TVTs being done in Groote with Linda Cardozo looking over Pete's shoulder. And you can actually see massive reduction in the number of Birch copper suspensions being done, which shows the belief in an operation by everybody really doing this kind of surgery, with massive reduction because of the uptake in the TVT. And you can actually see it was such a widely respected and such a widely adopted operation that there was a massive rise in the actual performance of it around 2010 when everyone was doing it. And I believe this was actually a good thing, that everyone realized it was a good operation. And remember, by 2010, it had been going for more than 10 years. I mean, it was 13 years in South Africa, and it was still remained a very good operation. And I think if there'd been enough of a problem, I think people would have stopped most likely before then. But there you can actually see, as the Scottish Parliament brought in this issue, a massive reduction in the number of operations done for political reasons, really. And you know, it's a pity, because patients were left then and remain you know, left without
high and dry, except they're not high and dry,
Yeah.
they're high and wet.
Exactly.
Because
Yeah.
the alternatives at the moment are not, shall we say, genuine kosher operations for stress incontinence. They don't give you the same effective cures.
Okay, sorry, there's not a question, it's a comment there. Okay, so there we go. So from 2016 already, there have been dramas, and they haven't really managed to reverse this whole issue satisfactorily in the UK, unfortunately, and they still can't do enough of these.
What options are they doing, Steve? Because that begs the question: if they're not doing TVTs, the number of women with stress incontinence hasn't decreased; it's the same.
Yeah.
What do they do?
So if you look at their decision aid, Pete, they take the patients through the bulking agents. They have the TVT in there, and then they also have the birch, and then they have the fascial sling, which is a TVT-like procedure, but you harvest a little bit of the patient's own fascia and you create a TVT out of that. So that's what they do, and those are the options that they give to the patients, which you and I both know are all less satisfactory than the TVT. So
and they're all old operations. The birch is from John Birch in 1950.
Yeah.
The Marshall-Machete Krantz, MMK, Marshall-Machete Krantz, is from the 1930s. The Stamy is from the early 60s. The Shlomo Raz talked about that also in the 60s. So these old operations have never been proven to be effective as TVT and have many, many more complications, Steve.
Absolutely. Now, admittedly, there are issues with the TVT.
Tell me about
as any operation. So there we can actually see the trocar going into the bladder. So with the retropubic approach, you can put the TVT into the bladder very easily. I have recently done it, and will unfortunately continue to have the odd patient where you put the trocar into the bladder.
But there are ways of preventing that. What do you do?
There are ways of preventing it. It's your technique. I've got a slide where I can actually explain it to you a little bit later. But the bottom line is that even if you see this on your scope when you do your TVT, it's not a problem. You remove the trocar and then reinsert it in a slightly different angle, and you'll 99% of the time avoid the bladder with your second pass, and it's not normally too much of a problem. So this isn't really an issue as long as you recognize that you've perforated the bladder. And then there are some other issues related to the mesh. This is a patient and a picture that I've shown many times simply because it's such a devastatingly huge complication. But this was a patient who had a TVT, that Curtis gear that ended up where they ended up missing that the bladder was perforated. But she was a really obese patient, and on day 2 or 3 she wasn't passing urine, and by about day 5 she was having urine leaking from her retropubic site, and ultimately ended up going to theatre and removing that tape that was in the bladder. But 1 or 2 days later presented with a necrotizing fasciitis, and you can actually see this massive infection of the abdominal wall fat that kept us in theatre on a Saturday afternoon for about 4 hours with the surgeon doing a massive resection of this necrotizing fasciitis. You can actually see she ultimately got a lot better and also lost a lot of weight in the process. But this is something that can happen, and would you know, be avoidable if you you know, were able to obviously recognize the fact that you were in the bladder and avoided this problem. But I mean, in hands where, you know, competence isn't really been achieved yet, you know, the complications will be there, as with any operation actually. But you know, maybe with a bit of mesh there, the forgiveness or the margin for error is a lot lower. And maybe that's where we are, why we do have these issues with meshing, that you know, when you do get a complication, maybe it's more difficult to treat. So there you can actually see how she eventually got much better and ended up going home, but you can actually see lost a lot of weight in the process.
Steve, what are, you mentioned that complication. Are there any other common complications of suburethral sling operation? We say TVT because the TVT is a much easier way than saying suburethral sling operations placed without tension. So we use the generic term TVT.
Here's another patient, again at Groote who had a TVTO, and she developed an abscess along the tract. And we took her to theatre and removed this whole thing. It slipped out very easily. She got better on antibiotics and came back for another operation a few months later, and she did well. This is probably the more common complication. This is you can see there's a little bit of mesh that is stuck into the vagina. This is called an exposure in terminology these days. It's not common either. From all the TVTs I've done, I've maybe seen one or two of these, and patients would present with possibly pain at intercourse. Their partners often the first ones to discover this with this irritation during sex. And this is actually quite easy to sort out. You can go in theatre and actually just cut that little piece of mesh out. Not difficult to sort out. And even when you remove this, patients often do remain continent. So not too difficult to fix. This is a patient who has a mesh eroded into the bladder. And now the question is, did this happen after the operation, or was this an unrecognized bladder injury? Difficult to say, but most of the time it's actually something that was done in theatre and missed. And this is actually very difficult to treat. And
How would you treat it?
Well, you'd have to go in with someone who's quite competent.
Urologist,
Yeah, and normally go in with the urologist to sort it out. Yeah, Yuga statement is and they really do support the fact that TVT is still a very good operation. Yeah, you can actually see some of these statements. Polypropylene material is safe and effective as a surgical implant. Despite all the dramas, I continue to use the polypropylene TVT, and I've had excellent results over the last sort of 10 to 15 years using it. The second one is that the monofilament polypropylene tape is the most extensively studied anti-incontinence procedure in history. The third one is midurethral slings are the first line treatment for SUI and represent a great advance for our patients. And then you can actually see the next one is that the FDA clearly stated that the polypropylene midurethral sling is safe and effective in the treatment of SUI. And even the European CNR, which is their sort of FDA type group, has also approved the use of these devices. So you've got good backing from the FDA, you've got good backing from the European, even the UK groups when you're doing these procedures. And I think even the South African Urogynecology Association put out a document maybe about 10 years ago about something like this. So I think you've got relatively good backing if you're doing this, as long as you can back up your training, your own competence, and maybe even audit of your own patients. So here we go. This is the conclusion from our Yuga. The polypropylene midurethral sling has helped millions of women worldwide to regain control of their lives by undergoing a simple day case procedure that allows them to return to their normal activities very quickly. And it's got acknowledged safety and efficacy, and it has enabled many women to access treatment. And in the past, concerns over the failure and invasive surgery caused substantial proportion of women, continent women, to live without treatment. And that really just goes on to say that really provides access to treatment for many women. So really just looking at some of the data.
Sorry, Steve,
yes.
I've just had a call. I've just had a message here from Habib
Yes.
of Nairobi.
Yes.
He asked a question. We've mentioned, he says, that TVT, polypropylene, is safe in the vagina. Why is polypropylene mesh not safe for use as a buttress for prolapse? Well, Habib, I think the big difference here is that when you have polypropylene mesh for prolapse, there's a much bigger area that is used, so the dosage is bigger. Number two, it's very shallow underneath the skin of the vagina. Number three, there's a much higher possibility of infection when placing the mesh than in a TVT. Number four, when a TVT is placed, it always has a sheath around it, and that sheath is protective against secondary infection by vaginal organisms. And number five, it's extremely well researched, which is probably not quite the same as the polypropylene mesh for prolapse use. So there are many differences in mesh for prolapse as against TVT. And for that reason, I think you're going to find a huge difference. Thank you, Steve.
Okay, great. So, and I think just to add on to that last question, I think in terms of evidence, we've got overwhelmingly powerful evidence to support the use of TVT. With the meshes, there were so many different shapes and sizes, different configurations, different companies. It was very difficult to get evidence to the level of where we are with the TVT. TVT is quite a consistent operation. It's even though you got different companies, it's a replicable operation between the different devices, and I think it's much easier to compare apples with apples. Where with mesh, you were often comparing, different devices that weren't very similar.
And the other thing, of course, is that people say, well, why can't I make my own TVT at a quarter of the price? Again, you could, but you're not then comparing apples with apples, and you're much more likely to get complications if you're making a snake oil ersatz device that has not been tested and studied in the same exhaustive way as the TVT.
Absolutely, and I think even for me, I've tended to stick with the same device, throughout the last few years, because I know how tight to make it and how loose to leave it, and even if I get a complication, I understand what's going on there. So just be careful moving between different devices all the time. You might potentially get into trouble, and that's why I sort of do stick with the same device in a way. But again, I think there is a little bit of a better comparison between the TVT and the meshes. But just to get back to some of the data, we have 5-year data, and this is also quite old, this study, but already quite a few years ago we had 5-year data comparing the different devices, the retropubic and the transobturator things, and really just to show you, that at 60 months, which is 5 years, the results remained really consistent, and with continence rates of about 85%, and that's what I actually quote to my patients. So you've got a relatively good chance of getting quite a happy patient if you do a TVT. And in fact, it was your friend Falconer and his group that were
Nielsen, Falconer,
the first guys. They were part of the guys who invented the TVT. They did the first data. They did the first patients. Yeah, they all did the first data. And already almost 10 years ago, they had 17-year data on the TVT.
And it's now well into the 20 years.
I don't know if they've published this further or on this group, but I do tell my patients about this data, and it's I think it was 90% of the patients in this group. There are only about 90 patients, but 19% of them were still dry. So I think it's, the patient will ask you, is it like a knee replacement that will last for a few years and you have to have it done again? I tell patients that I do it for life, but notwithstanding the fact that obviously, nothing can be guaranteed. Well, I mean, what do you tell your patients? Are you seeing patients back that you've done before, or are you still...
For knee replacement?
No, we're doing knee replacements now.
Well, I hope not. No, Steve,
no, I'm just saying for your
extraordinarily robust.
Yeah, I don't see the patients back that I've done maybe 5 or maybe more than I've maybe been in practice as long as you, Pete, but I'm not seeing them back with
Steve, this operation is extraordinarily robust.
Yeah,
the long-term outcomes are good. If the person has a cure rate after 5 years, the person's going to be cured after 20 years.
I think so too.
Yeah,
no, I agree with you. Okay, then just really getting into the Cochrane, which again, this is not the most recent one, but it's got excellent support from the Cochrane collaboration for stress incontinence, and you can actually see that with the exception of groin pain, fewer adverse events occur with the transobturator approach. But again, really a lot of support from the Cochrane review. And just looking at this data in a little bit more detail, looking firstly at efficacy and comparing just looking at the numbers in terms of the short-term efficacy. This fits in very much what I said earlier, about 85% cure rate for the different, for both the transobturator and the retropubic approach. And then looking at the different cure rates for the transobturator and the retropubic, I think there is a more likely chance of a reoperation if you do a transobturator tape.
Steve, now you only do retropubic.
I only do the retropubic.
And for what reason?
Because we know that the retropubic works better in a patient with a variation of stress incontinence called ISD, intrinsic sphincter deficiency. Some patients have a more of a problem with the sphincter than the hypermobility of the bladder neck. And you don't really know how much of the bladder neck is the problem and how much of the sphincter is the problem. And if the sphincter is a bigger problem, you're probably going to have less likely a cure than with the TVTO than with the retropubic approach. So I tend to only do the transobturator for that reason.
Sorry.
I do the retropubic only. Thanks for
Steve,
listening. I do only the
thanks for listening,
retropubic, and I think it really comes down to the success rate, and that actually you can actually see that the Cochrane data does definitely prefer the retropubic approach. Just looking at some of the complications, again from the Cochrane, the risk for bladder injury is much higher with the retropubic approach, but that's very easy to sort out. You just remove it. Voiding problems may be a little bit higher in the
sorry, Steve.
Yeah, absolutely. Yeah.
With retropubic bladder injury, are you still going to tell us how you avoid it? You said you were going to.
I've got a picture. I've got a picture.
Okay.
Yeah, I can show you in a minute.
Okay, we'll come to that.
You might get more retropubic, more voiding dysfunction after retropubic TVT, but again, that is easy, not too difficult to manage, to the point of where you might need to still go and loosen the tape at some stage. And then I think the biggest issue with all of these procedures is this groin pain. And if you do get a patient with groin pain who then becomes a chronic groin pain, that is a problem. And I've seen a few patients like that, and they really aren't happy. And that is probably the patient that will eventually go down into a medical legal route if you're not careful. So be very careful if you're doing these operations. And if you do get a patient with groin pain, be very, very vigilant in sorting it out quickly and successfully. And then just looking at some of the other complications, similar risk for mesh exposure, blood loss is maybe a little bit higher with the retropubic approach, and operation time, not really very relevant.
Steve, talking about blood loss.
Yeah.
What happens? How do you manage a woman that has got a retropubic hematoma?
I have seen that. You know that I've seen that.
I do know that.
I've seen a few patients with that. It's not a big disaster, but the patient obviously needs to be counseled regarding the fact that she's got this hematoma. But in every case, I'll manage it conservatively. And I've seen a patient, unfortunately, a really old lady who developed a huge hematoma of about 10 centimeters. But each time I've managed conservatively, and I don't go in and remove the hematoma. So there we go. Here's a little bit more data on the retropubic TVT. Sorry, let's go back here. Why I prefer the TVT retropubic. This was just another group from the Norwegian National Incontinence Registry, nearly 6,000 women. And again, yeah, the efficacy was definitely higher in the group who had the retropubic TVT. And so I think if you want the operation which has got the best success rate and also potentially with a lower devastating complication of pain, you should probably go for retropubic TVT. Groin pain after the TVT is variable, and I think you yourself, Pete, will recognize the fact that it isn't maybe as common as they might have reported in the literature. And again, it's variable, but I don't think the South African cohort of gynecologists and urologists who are doing this operation would agree that it is very high. And yeah, I mean, I don't think you even had that many either yourself. I mean, I don't.
Yeah, the secret and the trick, Steve, is to pick it up early.
Yeah.
And to treat it aggressively with anti-inflammatories, and also if it's excessive, I'm afraid to say that if it persists after aggressive therapy with anti-inflammatories and what's that neurological agent that we use? Lyrica. I would remove it as soon as possible.
I think resorting to, if it's not better within about a week or two, I would go and remove it.
I would.
Definitely.
Just before, if you're going to wait too long, two things are going to happen. The first thing is this: it's not going to get better. And number two, the tape is going to become inspissated and absorbed into the tissue, and you're not going to be able to remove it. You can dig it out, but you're going to cause more trouble. So if you want to remove it, do it sooner rather than later.
Yeah, I mean, if you don't remove it, I think a week is probably the maximum. That patient might end up with one of these big mesh groups, Sling the Mesh. They get a lot of support online from patients who have had mesh complications, and then you're going to end up with a downward spiral with these patients.
Yeah.
There are alternatives to TVTs, and we do have patients who really don't want a synthetic device. And one of the first and probably best options with the best efficacies may be the laparoscopic birch. So for those of you who aren't as old as Peter Young, who became very good at birches, the birch carpal suspension was an operation that involved working retropubically. So in Pete's days, they used to, when I was a registrar, I saw him do a few. They make an incision, like a fan and steel incision, go into the retropubic space, and with a finger in the vagina, they then identify the bladder neck and put stitches from the bladder neck onto this iliopectineal ligament. And they do between 2 and 3 sutures. And again, very good success rates, between 80 and 90% continence rates. And in your day, Pete, you guys became quite good at this operation, isn't it?
Yeah, Steve, but the problem is this, that if you had an alternative that was easier to do, why would you do it?
Yeah.
And it fell completely out of favor. I know laparoscopically it can be done, but it's not an easy, I mean,
Yeah.
you're a laparoscopic aficionado, and they're not easy to do. Those
Yeah, I can do this laparoscopically, but it's not my best operation.
you prefer not to.
Yeah, but I mean, it's fine. I've done, every now and then I end up doing one, and it's not something, the skills aren't readily available in many places in South Africa anymore, even internationally. It's not something that people get taught in their fellowships. But yeah, it is something I can do. And but again, what does it look like from an evidence point of view? There are data on this, and
That's old data. It's more than 10 years old.
But these guys did look at the laparoscopic carpal suspension versus the TVT. And yeah, you can actually see that the TVT again is favored from a pure cure point of view. So even from an operation success and efficacy point of view, the TVT is better than the laparoscopic birch. So, and overall complications, probably not much different, but different types of complications, much longer when you do laparoscopic birch and longer hospital stay. What about these single incision slings that we do? Sorry, this video is not playing, but there was a next generation of TVT that is a small TVT. It gets done through a small incision in the, again, like a TVT incision, but different devices come with different anchors that only anchor in the obturator fascia. What about the single incision slings? I do the single incision slings. There are some on the market. There's the Altus, there's the Solix, which is a Boston Scientific device, and there's the Ophira. They do generally work quite well, and the data is increasingly supporting the use of these devices. They are better from an groin pain point of view, Pete. They obviously don't come close to the bladder, so they're very unlikely going to perforate the bladder. But that said, you can still perforate the bladder with these devices.
Steve, these ones you've just mentioned, I'm not going to say their names again. They're still available, are they?
They're definitely available.
But
and
the TVT Secure was withdrawn.
It was withdrawn.
Why? Why was that withdrawn?
There was a J&J device that really had a very low efficacy rate. It was, I mean, success rates were down less than 40%, and it was probably due to the anchoring system that it.
Is that right?
Yeah. But
and they bled like hell.
Yeah, but the newer ones have a very robust anchor, which seems to work very well, and I still do them as part of my prolapse operations, sacral carpopexies, and others. I will add often a single incision sling. It's a much less invasive procedure, and if you want to add something to a procedure which is really quite big, I do quite like doing these. So I will use a Solix quite regularly on patients who have a prolapse operation. You want to do something prophylactically.
So they're prophylactic. That's an important.
I use it as a prophylactic. Although that said, guys like JP Rufus in Netherlands, they will regularly do something like an Altus as a primary procedure, and people are getting quite good results with it. So, and the data in something like the Solix, which they've looked at now up to 5 years, is actually not looking too bad.
Now, Steve, you wrote the Cochrane data review on single incision slings. Which, in your opinion, is the best one to use today?
Of the single incisions?
Yeah, of the single incisions.
I don't think any of them have really emerged as being the best. Yes, I'm still an author on the Cochrane review. I think we're in our 4th one now. but I have dropped quite far down that author list, to be honest. But the single incision things haven't really, none of them have actually been shown to be much better than the others. But maybe someone can correct me on that. But in terms of their efficacy, they are actually looking quite good. So I don't have an issue with anyone who wants to be using a single incision sling, actually. And then something that is becoming really popular and got a lot of marketing push in South Africa is this Bulkamid, which is a periurethral bulking agent. And here you can actually see this gets done through a very small cystoscope. And this polyacrylamide gel gets injected into the bladder neck about 1 to 1.5 centimeters away from the bladder neck. And you can actually see this operation being done. And the whole idea is that the bladder neck gets constricted by this bulking agent. You inject 4 places. Here you can actually see the surgeon is injecting it at the positions of 12, 3, 6, and 9 o'clock, but I tend to do them in the other corners, 10, 4, 8, and 10 o'clock, 2 o'clock, 2, 4, 8, and 10. Yeah, you can actually see some data. I'll just stop this. So this is not bad.
You're going to tell us when you do it and why you do it.
You can see now this, the caveat here is that you can actually see that this percentage of patients cured and improved. Okay, so, and it's not bad. I mean, 80% here is actually brilliant.
At what longevity?
Yeah, you can actually see as this video continues, you can actually see they've gone all the way up to 7 years with some of this data. So there is now an RCT data. There's Tommy Mikkola from Finland has done excellent work in looking at this device. And in the end of the day, this is a very good option that can and should be presented to every patient who comes to you complaining of stress incontinence. And I don't think you would be correct in your counseling if you don't absolutely include this as part of your options to patients.
Who's it specifically aimed at?
Pete, I mean, the indications are quite broad. The important thing you have to remember is that the complications here are almost negligible. It's a polyacrylamide gel. It's not going to be associated with much voiding dysfunction. It's not going to erode. Although I have seen one patient who presented with a diverticulum after Bulkamid, but I don't think that is something that should be concern to us. So in terms of the complications, very low. So I think I saw a patient today who wants a Bulkamid because she's just really not interested in a TVT. She doesn't want a synthetic device. She doesn't want even a vague chance of a complication. So that's where you would potentially offer it to a patient. That all said, there are people in Cape Town and also all over South Africa who are getting excellent results from this. And I suppose who should have it? The patient should have it by a surgeon who's really good at it. There is a learning curve. In South Africa, the support for this device is excellent in terms of the training. I know Kathy Lepley, who's part of the marketing for this, is great theatre support. So if you didn't want to do this, it would be really good to get them in theatre to show exactly how to be doing this. And so I think unfortunately, as JP Rufus says, the success rates of the Bulkamid is a little bit more related to what you had for breakfast than the TVT. So you'll get a bad day and you might not do it as well as some other days. Whereas I think the TVT's got a much more predictable outcome. So in my hands, I think the TVT is still better. But there are some people getting excellent results from the bulking.
So Steve, if people are counseled and they want an operation that is okay, but has not far fewer, but has fewer risks, perhaps a lesser success than a TVT, this is odd. Now, it comes to the old question of cost. Are these particularly inexpensive? Are these particularly expensive? Are they less than a TVT? And in this country, they're done under anesthetic in theatre.
No, see, that's the thing. So it is very popular in some countries where they're able to do this as an outpatient, in an outpatient type setting. Then obviously the cost is a lot less. And Tommy Mikkola is doing this under local anesthetic.
But Finnish women are extraordinarily robust.
He also does his TVTs under local anesthetic.
Freezing water and stuff.
In South Africa, it's not an option to do it in your office. We don't have really very good
reimbursement
if it's not done in at least a day theatre type setting. So again, it is more costly than a TVT in terms of absolute numbers.
Is it really?
It is. It's probably double the price for the actual device or the kit. So it is probably worth.
So you can't say that this is a cheaper option.
Not cheap in terms of what you're buying, but yeah. So, but I mean, it is reimbursed by the medical aids with appropriate motivation. You still do need to motivate in some patients. So, but you do get support from the company. So look, it's an option. I think everyone should be offered this as an option for patients with incontinence.
All right. Now, just before you leave Bulkamid, are there any other mid-urethral bulking agents that are kosher for the use?
Not in South Africa. We don't have anything anymore. We used to have macroplastique, and there was something called there were quite a few, but this is the only one that is available and that I would actually recommend.
And some of the other ones also withdrawn. I mean, colloid, bovine colloid was found to be unsuccessful as well.
There are some non-surgical options. The laser therapy has been shown to be effective in some patients, and the data is increasingly supporting the use of laser. Although that said, despite the fact that I have a laser machine in my office, I still don't.
It's a disclaimer.
Maybe offer as many patients this, but it is an option. And but by the time they're coming to you and they're leaking when they're on their runs, and they're very active jumping on the trampoline, I don't think the laser is an option. But again, it's not a bad option in patients who want something minimally invasive.
Perhaps an older woman.
Older women often want something that works as well.
More importantly, that
but
works.
the laser basically the fractionated laser, little dots of laser, does promote collagen formation and lay down, and it may actually work. And there is more and more data supporting the use of this. There you can actually see just some histological data where you can actually see that you get lay down of a thicker sort of collagen in patients post laser treatment. Okay, let's look at some of the complications. Avoiding the bladder. I used to, and sometimes still do, inject some local anesthetic retropubically, which then pushes the bladder out of the way.
You don't do that routinely.
Maybe I've got a little bit lazy, Pete, but it does work. And Lemise Ross, who was a fellow of mine about 5 or 6 years ago, looked at the data on this and looked at about 40 patients who had the injection of local anesthetic behind the pubic bone, and those who didn't, and reduced the risk of bladder perforations very significantly in those who actually did have an injection of this fluid retropubically.
And what fluid do you use? Saline?
Just some saline with maybe a little bit of lignocaine or marcaine, and it really did work actually. But more importantly, I think it's how you position your hand during the placement. And when you put this in, I think the real important thing is to drop your hand and to hug the pubic bone when placing this.
Can't you? I had a case like that, a colleague of ours that did this, religiously hugged the pubic bone and gouged the peritoneum to such an extent he got a huge hematoma over there and wouldn't stop bleeding because that interosseous, that particular area is well supplied with vasculature. And what would you do? The only way we could stop it was getting some bone cement and going cementing the stuff up. But I mean,
I think that happened more in the old days when you had the really thick TVT. But I think that the needle's a lot thinner these days, and I think the chance of that happening is quite low.
Okay.
Yeah, so I don't think we're really at risk of that. But the important thing here is to really drop your hand. You can actually see this needle here. If you don't drop your hand, you're going to spike the bladder over here. So drop your hand and make sure you come out correctly at the, behind the pubic bone. Transobturator approach, just really keeping your finger if you're going on an outside-in approach. This is from JP Riffers. I got this picture, but yeah, you can actually see what will happen if you get a big retropubic hematoma, and I have actually seen this myself in one of my patients. So just counsel your patients appropriately and warn them that this can happen. Hematomas would present with increased pain, urgency, a mass, voiding dysfunction, and even a drop in HP. So just bear that in mind. It can actually happen after a TVT if you're unlucky. I don't think there's any way of avoiding this.
So these hematomatas, Arun Kamisa uses the term hematomatas. They are, they happen, and they're jolly difficult to avoid. You would give her post-op, you'd give her, if she has a hematomata, you would give her some cyclocapron. And,
I mean, I don't know. I wish I could give you better advice as to how to avoid it, but there isn't anything. And
go to church on Sunday?
Yeah.
Yeah.
Bear in mind, in patients with voiding dysfunction, anyone who's got a drop in HB, anyone who's got more pain, the more of these procedures you do, the more you realize that the patients need to be quite well the next day. Anything that makes you seem the patient to be a bit off, just think about hematoma. And my radiologist in the hospital will tell you, I do CTs at the drop of a hat. Patient's not well after an operation, they get a CT scan, and that'll pick up a lot of complications.
And if you pick up a hematomato, you give them cyclopentone?
I give them antibiotics.
Anti-inflammatory maybe?
Yeah, by the time they've got the hematoma, I don't know if cyclopentone is going to do anything
Yeah.
to stop it from getting any bigger. But yeah, I mean, absolutely.
Something for pain, yeah.
But I give them antibiotics, and unfortunately, they do take a while to resolve. We're not talking about days, we're talking about weeks.
Yeah.
And the patient will present usually with some bleeding through the vaginal incision.
But don't drain them and don't go back.
I don't drain them. I think by draining them, you could introduce infection.
Yeah.
I mean, if you've got a sterile hematoma there, it's probably better than going in and starting to stick something in there.
Because you'll never find the bleeder.
But that all said, I did have a patient who had a sacrocolpopexy hematoma, and the radiologist went in and did a nice percutaneous drainage. She did excellently as well. So it is still something that we do, that you can think about.
But you wouldn't find the bleeder.
No, I don't think going in with a laparotomy to go and try and get that bleed is a good idea.
Okay.
Unless it's getting really bigger.
And then just give them blood. Okay.
Yeah, but look, I have had quite a few hematomas in my career, and we could spend the whole night talking about how to manage different hematomas.
We're running out of time, and Adam Alperstein's got a question he wants us to debate. So
yeah, bowel perforation, spectacular complication. There've been 8 deaths from TVTs in the US on the MORE database, which is their national reporting system. And yeah, I mean, we just say go to church on Sunday and say your prayers, because this is something that also a bit difficult to avoid. But
this is a cadaver picture.
This is a cadaver picture, but really just to show you how here's the pubic bone, TVTs coming through on both sides. And if you're unlucky, maybe obviously patient with some adhesions or some distorted anatomy for some reason, you're going to have a risk of a bowel injury, and that could potentially be quite devastating. There we go, 6 or 7 deaths in the MORE database. And just be very aware of a perineal discharge. I think the biggest problem for me is the patient who's got post-voiding retention. Really important is to sort this problem out early. The way I manage the catheters, I usually keep the catheter overnight. Some people do these operations as day cases, but I think it's prudent to just keep the patient overnight. Often you do these operations in the afternoon. Getting the catheter out and to get them voiding and to get them home is quite a big step. So I normally just do this as an overnight procedure. That's my preference. I instill 200 mils of saline into the bladder the next morning, remove the catheter, and if they are able to void that 200 mils of saline, they're normally good to go. And you normally know where you are in terms of the catheter. I don't always check the voided residual. But again, just, if they can't void, I take them to theatre within about a week. More than that, I think it's going to be hard to loosen the tape. But sort out the voiding dysfunction early, and I think if you are at all doubtful about the fact whether this patient is going to have a long-term voiding dysfunction, go and loosen that sling.
You loosen or do you cut, Steve? What do you do? Are you loosen or are you a cutter?
No, loosen it. If you manage it early enough, you always can loosen it. So the sooner you go, the better. But I think by the time you've hit day 7, you're probably not going to be able to loosen it very easily.
Might as well cut it.
Yeah, and don't whip yourself if you have to go and loosen one. It does happen. Just be grateful that you're able to sort the patient out quickly. And normally if you loosen it on like sort of day 3, 4, it's normally fine. Keep the catheter after loosening it for about another 3 or 4 days, and then take the catheter out. I normally take it out in my office. They're normally fine.
Yeah.
And they're okay. But if you leave it, don't be optimistic. It's not going to get better. If they're having difficulties voiding so soon on day 1 or 2, you're probably going to end up in trouble.
This is no place for optimism. This is a place for pessimism.
Bite the bullet, go to theatre, loosen it. The patient will be angry with you for a day or 2, but if she's okay after a day or 2, she'll be fine. And counsel her properly and warn her before the operation about that. That if you don't warn them about anything else, warn them about the risk of voiding dysfunction. Yeah. The patient who's going to think they're going to be in and out and back at work after a week is just be careful. They might not be the one that's actually going to be that lucky. Urethral issues, be careful. In theatre, you can cut into the urethra, bear that in mind. If you think you may be gone a bit too close, look, maybe if you see the catheter in the urethra, you've done that. Close the urethral incision. Maybe call a urologist if you really are worried. But urethral exposure, urethral perforation with the tape is actually quite a big complication. And that's where you could potentially, again, get into trouble. So if you do cut the urethra for some reason during this operation, definitely don't put in the tape. Close the incision and then maybe
Leave the catheter in.
leave the catheter for about a week and a half or 2 weeks. It's probably good to get a urologist involved if you aren't that experienced at urethral surgery, and maybe get someone else to do the next TVT if you can. De novo urgency, these are a problem. Patient comes and tells you, they were okay, but now they've got urgency incontinence after the operation. Be very careful in first year pre-op counseling. Tell the patient this could potentially happen, but we just manage those with some Betmeager, and it does often settle. So sometimes not the easiest type of surgeries to do in terms of managing pre and post-op complications. This is just an example of a patient that I had. She started leaking after the operation, and managing these patients is really important, and giving them good TLC, and it's good communication post-op. I think the most angry patients are those who don't get good for post-op follow-up and care. So just in terms of my conclusions, provide the patient with realistic expectations, choose a procedure that works for you, be vigilant for post-op complications, intervene early with post-op void dysfunction, and if they don't work out for some reason, investigate the patient carefully, and get help if you do need to get help from someone. There are some questions. Let's just have a look at these. We'll stop sharing our screen. We'll just run through these quite quickly. There are quite a few, so we'll try and be quick about that. The first one is Leonard Jewell asked, there's a Boys Impressor bladder support vaginal inserts on the shelf in the Walmart in Canada, different sizes, effective in young active patients with sagittal SUI. In my experience, available Amazon. Do you have any opinion on this option? Really just using a special pessary for patients with stress incontinence. I don't really use them a lot myself, to be honest, but I do know of these special pessaries for stress incontinence, and maybe it's something we do need to think a bit more about. And then Paul Blow wants to know, will you do a TVT in an obese patient with a BMI of more than 35? Do you regard this as a contraindication? Absolutely not. TVTs work very well in obese patients. The only problem is more technical in nature, and I have had patients where the TVT was too short to actually, the needle was too short to actually perforate through the abdominal wall. So I ended up doing, I think, a mini sling on one of those fat patients. So that is a problem, if potentially. Here's another, Leonard Jewell again. Do you think TVT placement surgical privilege should be limited to HBCSA registered urogynecologists? Definitely not. I think there are some excellent and very competent gynecologists and urologists who aren't registered urogynecologists, and most likely some of them are maybe more experienced than some of the registered urogynecologists. Absolutely not. I think your competence is related to your experience and your training, and how you feel competent enough to do an operation.
Steve, can I just chip in here? I consider you one of the very best, certainly amongst the 10 best urogynecologists in Cape Town. And if I have anything that is urogynecological, I will send them to you, because you're the best person to do it. Can I just quickly chip in? Alan Alperstein has made a comment over here, and before I forget, I just want to say, he's got a third of his patients are successful when they have TVT secure. That's just something. He loved your presentation, and he says the questions asked indicates a need for a discussion about large mesh and current management of prolapse. And that I think, Steve, is maybe you can address in one of the upcoming presentations. In other words, mesh. And
Like for prolapse.
that's right.
Yeah, look, it's an important discussion. I don't think we've seen the end of mesh because unfortunately patients continue to come with prolapse. They continue to have failures from the native tissue surgeries, and
Yeah.
we're just looking for a new wave of interest and support from the industry to develop these meshes, because they've run scared and gone out of the loop in terms of developing new products. Leonard, yeah,
Combrick.
yeah. How do you remove a TVT sling? Elaborate on your surgical method of choice. Very easily, actually, Willem. Always, depending on what you're doing. I mean, if you want to just loosen a sling, open the incision that you made a few days before. Identify the sling. I normally actually just take a Stilly's or Metzenbaum scissors, put the tip underneath the tape, and just give it a good pull. Don't pull too hard. I once or twice have pulled one out in trying to loosen it. I gave it a tug, and it
fixes the problem.
It came, and it just
introduces a new one.
And then I just put a new one in.
Yeah,
loosely. Yeah, it was fine.
Yeah, okay.
And I mean, just have to explain to the medical aid why you need to use a new one, but it's not a problem. And then how do you remove and then obviously you get patients who've got a more long-term chronic problem. Again, quite easy. Again, same incision. You often need to make a bigger incision because you can't find it. And then carefully looking for it. Then make a cut in the midline of the sling. Take a artery forceps or something, put that on the end, and then carefully dissect it off the urethra. And with enough experience, it's not too difficult. But make sure you go as far lateral as possible to either the obturator or the pubic bone to get as much of it out as possible. But again, very easy to remove. It's not the most difficult operation to do.
Steve, unfortunately, we're running out of time.
Yeah, one last, there are one or two other questions. I don't mind just answering them quickly. Yeah. On average, how long does the bulking agent effect last? I think they've got data up to 7 years, so not too bad. And I think when it works, it probably doesn't work too badly. Yeah, it's an effective procedure when it works.
The last question, Steve, I'll just say, thank you. It's from Anonymous. Thank you, says Anonymous, for an excellent presentation. Can you give us an estimate of the cost of a TVT procedure for cash-paying patients? Would anyone know if a TVT is done in public sector in Gauteng, and reply to Anonymous? See, I don't know how we're going to reply to Anonymous, but how much would it cost then to do a TVT for a cash person?
Look, the device itself costs anything between 8,000 and 10,000 Rand just for the TVT itself. And then I think if the person's charging medical aid rates, about, I think the code is 2548, and I think that on Discovery it's probably about 4,000 or 5,000 Rand.
5,000
Rand. And if they're going the classic rates, it's probably about 10, and then you're talking about anesthetists.
And
maybe about another 5 or 10. Theaters charge per minute, depending on where you're going to go. But you'll probably get a quote of a theater between 30 and 40,000. So yeah,
it's about 50,000 all in all.
I mean, depending where you're going, depending who you're asking. Yeah, but I mean, most surgeons will be able to give you a cash quote on that, and yeah, that's fine. But if you're living in Gauteng, yeah, at the Gen, they're doing lots of these. I mean, Chris Tostomo keeps presenting lots of data on this. So absolutely. I don't know what's happening with waiting lists, but if you go to the clinic there, you'll definitely be able to get a TVT by the guys there.
So that's good.
The Joburg Gen. What is it called now?
The Joburg Gen.
What hospital is that?
Generation. It's not the
I've forgotten the name of that hospital in Joburg. The big one there in Parktown area.
The big one.
So
the big Joburg Gen.
Yeah. Anyway, so Charlotte Paklake, isn't it?
I don't know,
yeah,
Steve.
But anyway, yeah, let's yeah. But
so anyway, it's the main one, and Chris Sostomo is the guy there. And it just remains for me to thank you, Steve, and all the people that have logged on. There's well over 100 people that have joined us this afternoon. And it's been a lovely, lovely presentation by Professor Steve Jeffery. And I look forward to having you all. Next week, we have Dr. Mpumi Zenda with us, Steve, and it's going to be lovely to hear her presenting. So we will advertise that in the course of time. Wendy and Karen, thank you to our technicians, and thank you also to our sponsors, the Pelvic Floor Foundation of South Africa. And we look forward to seeing you. Steve, it'd be remiss for me not to thank you for the use of your minibar.
Pleasure.
And I'll see you safe home, and see you all next week.
Thank you very much. And thanks to Pete for his hosting, and see you all next week. Thanks.
Thank you, Steve.
Thank you. Okay. Thank you.